foster. There you go. Hit your little, got it. Foster care, juvenile justice, and inpatient behavioral health. 75% are coming out of inpatient behavioral health. And so the bridge is, we have a contract with Healthcare Authority to bring providers, housing providers who serve unaccompanied young people facing homelessness and system agents and resources together to start having these behavioral health system talk to the housing system and to do trainings around what resources are out there for young people. So we are, I think this is our 7th or 8th month in operations, and I'm happy to say we were, our contract was extended. So the Bridge Coalition will be around for a while. And as I say, I look forward to talking about the Bridge Residential, which we will get into in a bit. Before I turn it over to V to talk about the Bridge specifically, let me just say that we're excited for today's training and thank representatives from the managed care organizations that are here to share some information on who they are and what they bring to the table. This is, in my mind, interesting and yet complicated. So we've asked them to think about a 3-part training. So today will be hopefully sort of an engagement and basic sort of engagement that sets the table for further conversations. With that, I turn it over to V.
Awesome. Thanks, Jim. Hey, everyone. I'm V. I go by they, them. And I'm a young person with lived experience in systems of care and homelessness as well. So like Jim said, we're a statewide collaborative between community providers, housing providers, like discharge planners and, management of care and just more. And our aim is to increase the number of accompanied young people who return to community with safe housing, with sustainable housing and services when they exit, instead of just simply discharging them to the streets, back to areas where it's easy to revert to unhealthy habits again. So with that, we have 3 main focuses. Our first is to provide cross-system coordination and training. So just between all of us, we all are familiar with what best practices are. Like Jim said, let's have some trainings involved so that we can stay consistent and just give young people and young adults the quality care that they need. So our second one is a return to community plan. So instead of simply saying discharge planning, which is associated really with, like I said, simply discharging young people into the streets, and add to the data, like Jim said, that a lot of them would return, a high number would return to homelessness within 12 months of their exit. We're going to create a return to community plan, which is to strengthen the process of discharge. So like I said, between all of community providers, we can help provide resources and just maybe some structure to help out everyone. And our third is to envision lasting reforms in serving resources. And we just want to, in this, identify the gaps that we're all missing. And we will have young people on board to help assist that, as well as community providers. And also just come up with goals for a legislative agenda moving forward. Yeah, back to you, Jim.
Thank you. Any comments or questions at this stage? MJ, would you like to introduce yourself? I'm kind of putting you on the spot, but you're one of our newest members.
Yeah. Hello, everyone. My name is MJ Negron. Don't use pronouns personally. And also, I'm just here as an advocate, mentor, hope I can gain some insightful knowledge and just be here.
Great, you're here. Thank you for reaching out. We're glad you're here. Okay, so again, I've heard the term MCO and managed care organizations for a lot of years. I was at Mockingbird when we went with foster care, decided to have a specific MCO. And yet it still feels just like this thing that I kind of get it, but don't really get it. And I certainly don't understand as much as I'm going to around how they can support us in addressing young people coming out of inpatient care and avoiding them being homeless. So I start by thanking them all. We had a couple of meetings. Scott Swan has been really great in helping be a liaison between North Star Advocates and his colleagues, and they've agreed to do a training for us. So with that, Scott, I turn it over to you with genuine appreciation for all of you.
Yeah, thank you so much, Jim. And let me see if I can share my screen, or you might have to make me a host. Nope, you don't. So I'll start sharing my screen, and then we'll do some quick intros. 1 sec, let me move everything around. I usually live in teams, so this is moving y'all in some real fun spots on my setup. There we go. So like Jim said, so thank you so much, Jim. We're really excited to be here and just share a little bit. We really want this to be more interactive, so we will kind of, and I know it should be sharing my slideshow, right? It is. Somebody nod. Okay, good, perfect. It probably has the slides on the site. Every time I move to presenter view in Zoom, it moves you all around and then I can't see you. So I'm just gonna leave it this way. But we'll do kind of a brief overview today of what MCOs are, some of the processes, and how you can get involved within your MCO and more leverage them as a benefit versus, you know, some kind of coverage I have that I don't really use or I don't really know. I even have the 5 different MCOs that are in Washington State up on there in our logos. We'll also share the contact information and how to engage in care management and care coordination here. But for anybody that's on Apple Health or Medicaid or what some people call Obamacare, you are enrolled in Washington State. We have 5 different MCOs. Sorry, I keep gesturing that way because that's what my screen is. But we have 5 here. We have AmeriGroup. This is in alphabetical order. We have AmeriGroup, Community Health Plan of Washington, Coordinated Care, Molina, and then United Healthcare. Where many folks might be enrolled in Molina. Molina has about half the membership. There's about 2 million folks on Medicaid across the state. About 1 million of those members are with Molina, and then the other 1 million are split pretty evenly among AmeriGroup, Community Health Plan of Washington, Coordinated Care, and United Healthcare. With Coordinated Care, as Jim alluded to, holding that foster care contract. So anybody that's in foster care is automatically enrolled into Coordinated Care. And then they also can utilize that benefit 1 year post-adoption too. So the objectives today, like I said, we'll do some introductions right after I kind of go over the agenda for today, but we'll do an overview of MCOs, what we are, how to engage, an overview of how to engage in care coordination or care management, and how to get us to actually work for you and help you out. And then we'll also have some time for Q&A. So we have about 30 minutes budgeted, so we'll leave at least a good chunk for Q&A. These slides are repurposed from another presentation that's really long. We only have about 15 slides, but we can cover questions at the end of each section. There's 3 very small sections today. So I'll introduce myself and then I'll pass it over to my MCO colleagues. But I'm Scott Swan. I use he, him pronouns. I'm our clinical programs manager for behavioral health here at Molina. And I'll pass it over to James.
Hi, my name is James Ingram. I'm a senior program specialist at Coordinated Care, and I work specifically with the foster care and adoption support youth and members, and I use he, him pronouns.
And hi, I'm CJ James Bruner. I'm utilization manager over at Community Health Plan of Washington. Nice to meet everybody.
Thank you so much, James and CJ. So I'll cover the overview of what MCOs are, and then yes, do not worry, I'll get the slides over to Jim, or I'm not sure if I should get them over to V, and then they can send out the slides afterwards. So perfect. So what is an MCO? Like I said earlier, a lot of people might just enroll, they might not really know. When I was on Medicaid, I didn't know there were 5 MCOs and how you pick one. I just picked one that I liked the logo of. And that's how I picked it. You know, a lot of people, they don't really know more about MCOs than that. They don't really know the differences between networks, the difference in contracts, the difference in enrollment, and what benefits may or may not be available, and the small differences other than maybe they've seen commercials for them, maybe you've seen ads and whatnot, especially during open enrollment. So an MCO by definition is a healthcare delivery system designed to manage cost, utilization, and quality. AKA a lot of people will be like, oh, that's your health insurance. And that is the majority of what we do, is where your coverage for any physical health, behavioral health, integrated managed care did happen in 2016. But sometimes those processes can kind of happen separately. But we basically are the payer for when you need healthcare. The healthcare authority signs contracts with us, and that way MCOs are the ones that manage medical and behavioral health services through our own networks of providers, we all contract differently with providers and work with them, and that's why we have different networks. So certain folks may say, oh, we take these types of Medicaid, but we might not contract with these. And then also in other regions of the state, through the RFP request for proposal process, some MCOs or managed care organizations are in certain parts of the state, but not in others. So there might not be all 5 in certain parts of the state where you might live. And then our goals really are to promote whole person care. So to really help address social determinants of health, and help identify care gaps that we might see. Sometimes some of y'all, if you're enrolled with them on Medicaid, you might get calls from us sometimes saying, hey, we noticed that you haven't seen a doctor in X number of years, or we've noticed you haven't gotten a vaccine, or you were prescribed this medication but never filled it. And we might follow up with you and we might outreach you. Yes, most of those programs are telephonic, and hopefully they'll evolve and change a little bit. I know there's some text campaigns, but hopefully things kind of will move into more responsive space, just since not everybody can always answer the phone. Our goals are really to, kind of reduce the cost of healthcare and kind of reducing preventable higher levels of care, and make sure people's needs are met before, like kind of moving upstream to see where we can identify issues and help problem solve earlier than later. And also to improve the quality of care. Every MCO has a different quality department where we're identifying care gaps, we're incentivizing providers, we're really working collaboratively with them to help identify care gaps, work with our members, and close those care gaps. And then we incentivize that through value-based contracting. And then the last goal is to deliver healthcare organized around managed care techniques and concepts, which is just to maintain those networks, make sure we have adequacy in all the regions, make sure that, when you need to go see a doctor, there are ones that have openings, take your insurance, can get you in a timely manner. More on just how we address and improve health outcomes. Like I said, we really do have a strong push towards those social determinants of health, or SDOH. You might see those sometimes, and those are more so of, it's kind of how we see health disparities or health inequities, and it's more of a sanitized term for that. So it's social determinant of health might be this community. I'm trying to think of one of my, so for the LGBTQIA plus community, about double the proportion, about 40% of folks in that community smoke cigarettes versus 20% in the mainstream population of Medicaid. So it's really addressing those and seeing how we can reduce that, whether it mean helping promote smoking cessation programs, helping doctors incentivize that through, like I said, value-based contracting to close those care gaps and maybe share that material. Maybe it's having a campaign like you've seen billboards for, and increasing smoking cessation or getting that service to people at no cost. Like I said, we kind of evaluate population health and other quality initiatives. So just like I shared, we would identify that social determinant of health, that health inequity that we're seeing within our members, and then see how we can kind of work collaboratively to address that. Every MCO does have folks that work specifically in health equity, and that's kind of what we look at. And then also contracting with a network of providers that just make sure we have your needs met at all times. And then also, like I said, sometimes we might reach out to folks. It's kind of monitoring that high cost, high utilization. Is somebody going to the emergency department for different reasons? One could be they are experiencing homelessness, and if they access the emergency department, they would be housed that night. How do we actually connect with our members, connect them to other housing resources, and help go upstream to help with that issue? And then the last slide I'll cover before I hand it over to James, the different types of coverage. And sorry, I'm going to bore you with insurance stuff, but we do, like I said, we had integration in 2016 of the MCOs where we kind of had physical health and behavioral health merged together. That being said, we still do have separate provider networks. So we certainly, we might have somebody that's technically a physical health provider and we contract with in a different way than we might contract with a behavioral health provider. That being said too, we might contract with somebody differently for substance use disorder treatment, and those are paid at different rates. Contracting looks different. Providers might be contracted for one service or not, or they may for the other. That could be for a whole different host of reasons, whether they're the folks they have on staff, the rates that get paid for those services, the demand in that region. It could be a lot of different factors that kind of play into that. And just like that calls out too, is mental health and substance use disorder are merged together as one is behavioral health. But like I said, that doesn't mean that just because they could be contracted for both, they could be contracted for one or the other too. It all always looks a little different. Some behavioral health services not covered by MCOs are listed up there, but there's certain things that just aren't in the state plan and that MCOs don't cover. There would be other systems of care that would cover it, other folks that would be the payer. And we can kind of go into that if folks do have questions on it. But a few examples there are like rehab case management, urinalysis testing. Certain things are covered differently. They might be covered. I'm not going to bore you with a bunch of acronyms and funds, but there's different pots of money that are out there that would cover it. And sometimes the MCOs do manage it or have a hand in it, and sometimes we don't, or sometimes we work collaboratively with those systems of care. And then some folks may be fully enrolled in IMC or integrated managed care, and that means we are the payer for all of your healthcare. Some folks may be enrolled in BHSO coverage, which is behavioral health services only coverage, where we would be the payer for just behavioral health services. And then you would have a physical health payer. Sometimes we're also secondary. Some folks might be double coverage, where they might have a primary payer and then a secondary payer. Or you could have benefits through fee for service, which is where providers will contract directly with the healthcare authority for those services. Or you might have other third-party coverage like commercial insurance, or other insurance through your employer. So that being said, pass it over to James. Just tell me when you want to move to the next slide, too.
Okay, thanks. So this is talking about behavioral health administrative service organizations. And so as a MCO, we are required to contract with those, and some of the services that are provided, crisis services for both adults and youth. So there's a 24/7 crisis response line that you can call, as well as the crisis hotline that's listed below. There are mobile outreach services. So if someone is experiencing a crisis, someone can come out to their physical location. The designated crisis responders are usually within the hospital. So usually you'd see them in an emergency department type setting. And then ITA evaluations, where someone gets involuntarily admitted, that's in an inpatient setting as well. And there are certain criteria that are pretty complex that have to be met to go ITA. Okay, next, please. The grievances, this is somewhat of a dry topic, I'll admit, but it is important to note that if you are enrolled in an MCO, you do have the ability to file a grievance. So it might be for a medication not being covered. It might be you get a bill for something, which you should not. You can file a grievance with your MCO to then address that bill for you. And then you can make an appeal if there's something that you don't feel is going correct with the way you're getting your treatment from your medical providers, whether that's behavioral health or physical health. Most of the grievance departments have a certain time frame in which they have to respond to that. Here it's listed as 45 days. So hopefully it's a quick resolution. All right, next. And another service that's available to you is being enrolled in an MCO as a behavioral health ombuds. Can never say that correctly. They can help resolve those complaints and grievances, as well as assist with those appeals. And then the last step is an administrative fair hearing. And there's the contact information through the healthcare authority below that you can access those. And unless there's any questions about those three specific areas that I covered, I will pass it along to CJ.
Hello. So, gosh, thank you. So now we know that you guys have coverage, right? Or all Medicaid, and what that looks like. But with managed care organizations, there is also care management that is provided that we'll be talking about in a little bit more detail.
And right before we go into that, I saw MJ had a hand up.
Yes.
Yeah, I did have a question. Just on like the ombudsman. I know like when some people call them, they often have their mailbox full. So I was wondering if there's other things out there that people can call to report their grievances.
Oh, that's, I can take that from, yes. Actually care, or unless James, you have anything else you want to add?
No, you're gonna cover it with probably what I was going to say. So go ahead.
Okay, yeah. Each MCO has a care management team, and this would be a good place to start, is to work with your managed care organization. Ask for a care manager, whether it's care coordination or case management, and that individual will help walk you through other steps and to connect with somebody with on who has who's providing on-spud services. And so we'll talk on the next slide what other things they can do. So when we get to the last slide here, all the contact information is going to be there for everybody. So that would be the next step if you're not getting any contact in contact with OnSpuds. Sorry, I'm just kind of stumbling over my words today. So care management is, through all managed care organization, kind of is goes under two umbrellas. There's either care coordination services or case management services. The focus for care coordination is really around those short-term needs. Do you have the providers you need? Do you need any assistance with transportation, your appointments, all those basically entryways into more supportive longer term care for each individual. They can be provided by either an unlicensed individual or a licensed. This is maybe provided by unlicensed or non-licensed staff. I know that a lot of the stuff that we're doing here is you're going to see a mixture of both, either licensed or non-licensed, but that the purpose is that it's, you're not getting an actual clinical perspective. You're having somebody who's helping you identify what those needs are. Did I see another question pop up? No. So the purpose of this is to address any social needs that that individual may have, connect them to the resources, whether it's housing. Sorry, what's going on? Okay. Okay.
I was just correcting the slide.
Okay. Sorry. Any social needs, whether it's housing, or getting connected to OMS anything like that. That's a good, this is a good place to start. And so the other one, I want to make sure I'm touching all of them. Oh, the other key too is that this is a voluntary service that's being provided. So nobody's forced to take on this, but it is there, and I have to say it's very, very helpful, especially when trying to help navigate through the medical and behavioral health field, world out there. So that's the care coordination is the short term. Now, sometimes individuals will need more support. So that can be with a referral to a case manager or case management team. And usually these are provided by a licensed staff and some non-licensed staff. We have nurses, therapists, social workers, a bunch of individuals that are there to support you. And so they're there to help you. It's actually kind of cool. It's a goal setting collaborative effort. You're doing like a care plan, identifying needs, what that engagement is going to look like. Maybe you're going to connect with your case manager once a month, twice a month. It's all based on each individual's needs. And once again, this is very much a voluntary service for everybody who's under a managed care organization. Yeah. The next slide. The umbrella term that includes here. Sorry, I have to look at this again. So tips for requesting care coordination, and this is actually really, really important, is be specific to what your needs are, what you're asking for. Make sure if you're for youth, make sure you're also discussing this with your with a guardian for a prior referral. If there's referral. So I'm repeating myself. I'm so sorry. I read these slides earlier, but sometimes I also have in my brain, like, this is what you need to do. That managed care organization is going to take that referral and triage it and decide, okay, where within our services for managed care is it going to be best fit? Also, we have communication to and from managed care for our DDA team is really, really critical. There's great collaboration with DDA, so make sure if that's a need that's communicated. Resources, and here's our care management referrals. Each individual managed care organization has contact information here in this slide. And the next one. And here we go, some more information from each MCO's phone numbers and websites and all that good stuff. So any questions about managed care world and services and supports?
Can we stop sharing so we can see more, so I can see more of
Totally.
the faces out there?
Yeah.
You know?
Yeah, I see a couple of
Yeah.
questions in the chat, right?
Great. Can I ask this as an overarching thing to make, I think we're at the stage of just trying to make sure we as a group are on the same page of a basic understanding. So MCOs, managed care organizations, they, and Rachel can chime in here because I know she's got some good expertise on this. But so it's an insurance company for my physical and behavioral health. Is it a fair statement to say most Washingtonians, maybe all Washingtonians, either have private insurance, they have no insurance, or they are involved with a managed care organization? Is that a simple but basically accurate statement?
Yeah, I'd say so, Jim.
Yes.
I think when you think of a managed care organization too, keep in mind that that can oftentimes also include Medicare. So it's not a huge portion of our memberships, but it also includes that. So yeah, it would be uninsured, covered by an Affordable Care Act product, or commercially insured.
Yep.
Great. And I have some others, but I want to make room for folks. Rachel, do you want to just come off? Are you willing to come off and ask your question?
Yeah, I was just wondering for the group, if you could explain how an individual that might already be in the emergency department or is in an inpatient facility and needs that care coordination or needs case management, how would they apply for or complete the referral? And is a provider able to do that for them?
Yes, absolutely. The provider, if they're in a hospital setting or an ER setting, they can definitely assist in making that referral. There's all the information. They providers have all of managed care organizations as well. And if that individual wants to, while they're there, usually at if they have their card, and not everybody does, but if they did, there's information on the back of their card on how to make that referral as well. But asking the hospital provider at the ER, they can get that information for your managed care also to make that direct referral.
Also, one thing to add too is I would recommend, if somebody's in an emergency department or an inpatient facility, to mark the referral as urgent. That way, typically it takes us about like 5-ish business days for typical referrals, but for those urgent ones, it depends on the MCO, but we typically get to those same day, if not 2 days. Unlike utilization management, where we have strict turnaround times, we don't have those, so I can't speak with absolute timeframes. But yeah, I would always recommend putting urgent in that email line, which I'm going to add to the case management referral on here because I think that's a good thing to call out.
And to add to that, if they're inpatient or in an emergency department, I would also suggest they talk to the social worker on the floor.
Right.
That's another avenue to get them connected to care coordination or case management.
Would you take?
Go ahead, Dee, please.
Oh, my bad. Would you take similar steps if you were in involuntary detainment? Just a little background. I was in involuntary detainment for a few days, and when I was at the certain facility that I was at, I I wasn't assigned any care at all, and the social worker that was assigned to me, I had no idea. So I was basically there for 5 days and had to advocate for myself to not stay an extra 14 days, if y'all are familiar with that. Because usually a case manager will come in and be like, they'll listen to you and they'll be like, actually, I think you should stay for another 14 days, regardless of what your situation is. And it's like, no, I don't know what benefit. I don't understand the benefits. Like, you're just stuck here pretty much like jail style, like there's nothing simulating. Anyways, that's just a long way to say, like, how do you come about, like, what steps should you take to receive like the resources you need or get connected with or get a referral when there's really no one there that knows what they're doing, or like there's no one really assigned to you.
Yeah,
Yeah.
I can speak for Community Health Plan of Washington, and then please feel free other MCOs speak about. We have our team who does those reviews for all admissions, and that person that's doing the review is also reaching out to try to talk to that person in inpatient, and try to talk to that social worker or whoever's working on their transition planning, so we can have that collaborative conversation, whether you're voluntary or involuntary. And if you feel like anybody is ever in any inpatient setting and feel like their voice isn't heard, and their ONSPUD is, that's a great direction to start as well. And your managed care organization can help you make that connection.
Yeah, only things I would
Is
add.
there Oh,
Yeah,
go ahead
you go
first.
first. Yeah.
I was gonna say, are they required to, how do I word this? Are they, when you enter that facility, involuntary or inpatient, are they required to like tell you what's going on and the actions you can take? You're like, I don't know. But yeah, like I had no idea what was going on. And I have like, I would say I had the privilege of being high functioning, if that's a way to say it. I don't know. But I think everyone that I was grouped with, and I was like 18, I was grouped with a lot of adults, which didn't make sense to me. But also these adults were more, they were less in reality, I'd say. So like you couldn't really converse with anyone there, on top of the staff that were really young themselves, covering swing shifts because they have to. Yeah, all that to say, are they required to give you like
Yes.
steps on what to do? Yeah.
Yes, absolutely. You should, upon any detention, wherever it is, whether it's out in the community or within in a hospital setting, you should be receiving court documents explaining why you're there, your next court hearing, your appointed counsel at the time. All of that information should be provided to you. And if it's not, then that's a concern if you didn't receive that, That's why the advocacy for your health is very important.
Well, I'll just say this, and I thank you, V, for speaking up, and that is the value of honest lived experience. So your courage shows through. We heard that a lot in the report that we created when I was at Away Home Washington, young people's experience of feeling they were either infantilized because everybody else was so much older, or they were not really listened to and not viewed as having a sense of what their own health needs are. And then, quite frankly, and the data shows this is why we're here, and then discharged again to an emergency shelter, to a drop-in center that has no beds, frequently with no meds. And I've talked to inpatient staff, and again, I just want to say no bad people here. But in a dilemma, well, we knew they still had soft suicidal ideation, so we didn't want to give them their meds, but we knew if we didn't give them their meds and we sent them to a place that didn't have the information and the expertise, then decompensation was probably right around the corner. So again, not asking you to take responsibility for all that, just sort of giving voice as to why we're here. And then if you could talk a little bit about 1860, with through the filter of why would someone who's running a residential program for young people, why would we care about or want to know about MCOs? And I think some of that answer is in 1860, but love to hear your thoughts. We'll come right to you, MJ. Thank you. I got you. So yeah, in your, all of you respond to the 1860 dynamic and just how do you all help a very busy provider who just had a young person sort of on their doorstep show up?
I can take it first and then
Oh.
y'all can add or, oh, sorry, were you gonna go first? Sorry. Okay. First up, Jim, I did want to address something you brought up earlier too, is if anybody ever gets discharged without medication, typically that's not allowed. If somebody is experiencing suicidal ideation, and that's one of their concerns, you can always discharge somebody with blister pack medication. Sorry, I worked inpatient and with ITAs for quite a while. And those blister packs are just as they sound. It's kind of the same way we do medication in the UK, actually, is a lot of those medications when somebody's experiencing suicidal ideation are provided in a blister pack. It just gives that extra little bit of time so that somebody, if they are having those thoughts, they might be acting on impulsive acts. It takes a lot longer to punch it through. Even things like some of the typical over-the-counter medications too that can cause liver damage that can be fatal are administered just in blister packs for everybody. So that's one thing to just address with what you were sharing, Jim. But to address 1860, 1860 is a House bill that was passed, and I think it went into effect about 1 year ago. I'm not positive on that. CJ, correct me if I'm wrong on that, or it might have gone into effect the first of this year. So it's been in effect for about 11 months almost. What it does is it mandated that anybody that is identified as having a housing instability, or they might be discharged into homelessness, the hospital has to connect with the MCO and make sure that they have identified that this individual is experiencing either housing instability or they're going to be discharged into homelessness. What House Bill 1860 did is that additional connection. What it didn't do is it didn't create new housing resources. It didn't create additional funding. So while it does connect us to you and it identifies that issue, there's not much more we would be doing than connecting you to the resources that are available that hopefully the hospitals or inpatient facilities connecting you to. But that does help increase the communication between MCOs and providers. So that is one of the big benefits of House Bill 1860. Like I said, further legislative advocacy is going to be needed to increase resources and funding into that system. But it is a good first step. So not to sound pessimistic about it, it is a good first step. Not sure if that fully answers your question, Jim, or if CJ or James have anything they want to add.
I have a
Yeah.
little bit. Okay.
Please.
Just a little bit to add. This was put into effect, to support that communication. But I'll be very honest with you, sometimes that communication doesn't happen. So if you are experiencing housing insecurities, or you're working with anybody that's experiencing that, or if you're in an inpatient setting leaving and you didn't get any resources, but you see within 72 hours on your phone, your managed care organization is calling you, pick it up. We're following up on your stay. We're seeing, how was your stay? Did you get what you needed? What do you need still? And we're there to help bridge that connection between what was lost, or to support you getting to those appointments that were set. So if housing was at risk before you got in and now is at risk when you left, and now you don't have housing, you didn't know about it, talk to them. Each managed care organization has specific groups that focuses on this housing and making those connections. Like Scott said, unfortunately, the increase of housing hasn't gone up. The need has. It's kind of I feel, this is my opinion, it kind of put the horse before the cart, as you may say. So, but we can at least be there to show what resources are there, point you in the direction to get on whatever services are there to support you. That's why I'm excited about this service that you guys are putting together.
I was
Thank
going
you,
to say the Bridge
Susan.
Residential feels like it's bringing some resources to 1860.
Mhm.
Scott, did you want to say something before we take another question?
Oh, I was just going to take Bridget's question. Sorry.
Oh, yeah.
I think just one
Well,
thing to add.
MJ and then Bridget. Sorry.
Oh, yeah. And then James had something to add too. Sorry.
Oh, go ahead, please.
Just to add to that, what House Bill 1860 did is at least the MCO is now notified that that's an issue. So that's something that we're aware of instead of just you were discharged, you as in the individual being discharged, and we as the MCO were not aware that that's a type of resource that might be needed. But now we're at least alerted to the fact that that is an issue that we might be able to assist with.
Thank you. MJ.
Yeah, I had a couple statements, suggestions, questions. So I was thinking, kind of going back to like helping out with discharge, perhaps having a representative from the patient's insurance, like a case manager, to come to the facility and sit down with them and being like, hey, this is the process for like when you get out, to kind of help with discharge planning, and to just be like, to kind of make the process more streamlined. And since it's already somebody from the health insurance, then they'll already have that connection in place. Another thing that I was thinking of is phones. You know, like I know there's government phones and stuff like that, but if we don't make the connection before they leave, how can we sustain a connection after they go? So there is that piece. And then to touch on also about like patient rights and responsibilities, they give you like a pamphlet or like, you know, just a couple documents that you have to read through. But what really gets to me is that some of the medications that they put you on will make you too sleepy, too drowsy. I recall from my personal experience, like I couldn't even show up to my court hearing. The lawyer advocate person did, and I was like, all right, but I was too tired on meds that I wasn't even supposed to be on. So it's like, it's kind of like a catch-22 when you're talking about these things, and like having the patient be aware of those things is one thing, but having that sustained, like, you know, like they have groups, right? But the groups don't talk about like your rights as patients. The group meetings, you know, talk about like how to control anxiety and depression, but there's not like a structured, oh yeah, by the way, you should probably look into your rights and responsibilities pamphlet to try and see what we can do to manage your care better. That's all I was gonna say. Kind of a lot, but yeah.
No, that's really good. I guess one of the points, it sounds like a hotline to my MCO or something like that makes really great sense. But it does sound like we're expecting, so how do you contact your MCO, contact somebody? Like that's a lot of pressure to put on the person who's actually experiencing the crisis and the need for healthcare. And it just seems like that's a dynamic that, yeah, before we go to Bridget and then Matt, I don't know if there's anything y'all want to say about that dynamic, that it's.
Yeah, thank you. And I'm sure CJ and James will have stuff to add, but to kind of address the 3 points that you brought up, MJ. The first being that the MCOs do have some staff that will come into hospitals. At least I'm speaking for Molina. Each program looks a little bit different, but we do have transition of care coaches that do some in-person outreach. Some of the hospitals are more welcoming of this than others. But we do have staff that go in person to connect with you, share resources, identify, do you even have an insurance card? So you have those resources that are on the back of it. And if you don't, we're getting one mailed to an address. If you have it, if you don't, then we're working closely with you, either getting email information so that we can keep in contact with you, which kind of dovetails into what you brought up, MJ, is most MCOs do have programs where we give our members free phones if that's identified as a need. So there are, in addition to what some people call Obamacare phones, we do have other phone programs too that we can provide phones with. I know for us too, like there used to be minute limits on them. We don't have those anymore, at least at Molina. And then with those patient rights and pamphlets, yeah, not putting the onus kind of on the person that is experiencing a crisis and something where their first thing probably isn't, oh, health insurance. That's probably not the forefront of your mind. Yours is mostly focused on survival at that point. We do have those pamphlets info. We would connect with you in a way that works if there is contact info. And like I said, if you don't have a phone, we're getting one to you. So, but one thing to kind of highlight too is a lot of hospitals aren't even aware of MCOs and how we have these programs and how we can help connect with you. And that's why a lot of the times you might, you might be even hearing me, anybody with lived experience on this, hearing me say this, like none of that ever happened for me. And that might be the hospital isn't disconnected. Maybe they were focused on, and I'll use this term intentionally, discharge planning versus a return to community and clearing that bed out to get a new person into there. They might have been focused on that versus really helping you on your having a successful return to community. So I'm not sure if there's anything James or CJ would add to that. No.
I don't. That's very nicely said.
Yeah, that was pretty comprehensive. One thing to add is, and CJ probably knows this way more than I do in her department. We do get generally notified when one of our members goes inpatient, and then as care coordination or case management, we're trying to reach out to either the individuals who's hospitalized or their care team there, whether that might be the provider or the social worker on the floor, to make sure that before leaving the inpatient facility, you're connected to the resources that you need. It doesn't always go perfectly, but that's the intent of part of what managed care organizations do, is to connect with you while you're inpatient.
Yeah, and I think you bring it really also, like, it doesn't always happen the way we want it to happen, right? We're reaching out, we're trying to collaborate. One of the things that we've been doing the last few couple of years is identify like which hospitals are struggling to communicate with us when we do reach out, and then we would do a training on, this is what we have, this is why we're calling. We're not just calling to be nagging. We want to call because we are trying to connect with the members, trying to support you, brainstorm, safe transitioning and all that. So it's just another thing I want to put out there, is that once we see if there is a challenge, we're trying to collaborate to break down those barriers.
Bridget.
So this is, I don't know, might be a weird question, but you had mentioned earlier during the PowerPoint thing about value-based payments versus fee for service. I think a lot of people who would like to be able to do this are trying to get away from fee for service because it is rather burdensome as opposed to value-based. So for us providers, and I'm a provider, for work at Volunteers America in Spokane and have lots of different housing programs, and we're a behavioral health organization, trying to figure out, it's a sustainability issue, it's efficiency issues. There are a lot of issues addressing that value-based as opposed to a fee for service that's going to encourage perhaps more providers that are working with the vulnerable populations to be willing to do some of this work if it wasn't tied into a lot of those administrative strings, the fee for service, which is a lot of paperwork involved in that. And I don't know if any of you really are at that level or understand what the timeline. I know that there's been talk, and I just keep hearing that there's talk about going to a lot more value-based contracting. Do you see that as helping to expand the capacity and the actual housing options for not just the young people, but also anybody getting out of being discharged, and making sure that they're not discharged to the streets? That was a pretty broad question, wasn't it?
Somewhat,
No,
but
it's a good question, Scott. But before you answer directly, can you give this C student a kind of a 1 or 2 sentence definition of what value-based? I think we know what fee for service is, but what value-based, just for us to be on the same page.
So what I believe you're referencing, Bridget, is more value-based contracting that MCOs might be doing with providers. And it might be something where we identify one of those health inequities or social determinants of health, like, hey, this provider, if you can, so here's one example of value-based contract. I won't identify the provider, and these numbers are made up. So I only know enough to be dangerous too. I don't think any of us are deep enough in contracting to fully answer your question, but we can definitely connect you to the right people. But one example might be like, hey, this provider has a high proportion of members that utilize the emergency department for what we call preventable, whether, hey, my child has the flu, and you took them to the emergency department instead of like utilizing, we do have telehealth providers there. You could stay at home, you could get into the queue, they give you a prescription, you'd go pick it up instead of having to go get exposed at the emergency department, take hours of your time. The value-based contract might be, hey, if you can reduce the incidence of our members for every 8 out of 1,000 members we have accessing the emergency department, you can reduce it to 4. We'll give you X number of dollars. And so it gives you a carrot on the stick to chase as a provider to get more money. And that is one of the ways it might make your practice more sustainable versus, hey, look at these rates. We do the math. If we pay all the staff, we don't make money, which is one of the reasons why some MCOs might have difficulty with provider networks or having providers in network is sometimes the rates that are kind of set don't set it up to be as sustainable as it could be. Or commercial payers might be paying so much more that some providers might not contract with Medicaid. So I don't think I'm going to be able to fully answer your question, Bridget, on timeline. But MCOs definitely are getting a big, strong push from the healthcare authority. And we all are making it more of a priority to increase the number of value-based contracts we have. They're identifying more of the health inequities we're seeing within our populations and creating value-based contracting around that. But one thing I could say for you, if you did want to explore that, I would just recommend connecting with or have the powers that be over there, whoever connects with contracting, say, hey, we're interested in value-based contracting. Are there any incentives out there? Are there any contracts we could engage in where, maybe
Right, and you can see it'd be a benefit for the bridge program that's being proposed to begin with, because again, if these young people are actually not going back out on the streets or avoiding being on the streets initially, that's a huge health determinant for them. I mean, and if there's a way to support programs that are doing a lot more work around that, that always is going to become a huge saving for MCOs and everybody else. Yeah, I just throwing that out there, putting a little thing, and Jim's thinking, just putting a little thing in,
You are a genius. I was going to ask you for an example of how value-based contracting would come alive for young people,
Right.
organizations serving young people facing unaccompanied homelessness, and you just did that.
Right.
Avoiding homelessness in the first place or not
Right.
going back. Yeah. Are there others that you guys are thinking of, examples?
Oh, that was
For
directed
you,
at me?
yeah.
Oh,
I'm trying to bring this alive for the unaccompanied homeless providers in our world.
And that's probably the biggest one is about preventing
Okay.
homelessness to begin with is probably the biggest one, and the health pieces, and those really, that's the focus as far as I'm concerned, and just moving towards more value-based where it's, again, doing the fee for service, and I'm sorry, value-based might not be as good as fee for service, but it's also a lot more efficient as far as not spending all that time billing. That's a huge, drain.
Right.
So, I mean, doing the value-based and then tying it to the preventative pieces. They're stably housed or somewhat stably housed. They're in school. I mean, all these things that come with experiencing homelessness, they drop out of school, they're on the streets, nutrition, physical health,
Right.
the trauma, the victimization, all those things that are part, sadly, of experiencing homelessness for a lot of these young people can be mitigated if they have strong, safe, stable housing.
Well, and I
And
think
it's a lot cheaper than ending up being homeless for the next 40 years of their lives and the costs on our society as a whole. Sorry, I'm done now. I'm done preaching.
No, please never be done. But even to the example earlier, like another example might be they start going to regular physical appointments rather than using the ER when they're in crisis, have a physical, like I can really see it coming alive. So we're thank you guys so much. We got a few more minutes. Matt, do you want to ask your question, and then we'll close out with V?
Yes, I will ask it, and I unfortunately have to jump off for a meeting with a Mockingbird chapter, so I apologize for having to jump early. But yeah, my question was related to the reporting aspect of 1860. I'm curious about how providers are communicating that information to MCOs, how it's stored, and sort of like how recoverable and usable that data is. And in particular, like, is it passed on to other entities like the healthcare authority?
I'll answer it really quickly, Matt, since I know that you're a minute over for your next meeting. But the way it's shared with us is it's in the subject line of the authorization that gets sent to the MCO. So what they do is they have to identify it within the subject line, just like an email kind of subject line. They write down, hey, this person is unstably housed or might be experiencing homelessness or might be discharged into homelessness. That is all that House Bill 1860 kind of did, is that's the information that's shared. The provider can kind of choose how much they want to share on there. We store the data in that we store all of our prior authorization information in fact sheets, those facts cover sheets. And so it's stored here, but House Bill 1860 didn't mandate kind of that we forward that along to other entities. I think that would kind of broach into, and sorry to hide behind the shield of HIPAA, but I think that would be kind of sharing private health information if we were to re-forward on that information. So that's the only concern I can think of there. So it's not really forwarded on to any other system partners. But yeah, to answer your question, that's how it's shared with us, and then it's stored in our databases. But it's, yeah, adding, hey, we're going to write down the issue in the subject line of this cover sheet is, yeah, one step towards solutions, but not the solution.
Thank you. I appreciate
Yeah.
the answer.
And
Thanks, Matt.
for
Go ahead, please.
for CHPW, we're getting the information the same way. We're also following with our transitions of care collaboration with our members. We're also asking directly when we do get a hold of our members, is housing something that they're in need of. And then that's part of our assessment. The other stuff, I'm not sure of. I'm not on that where it goes. I know we don't for HIPAA purposes, but that's another way we collect our data and support. It's really goal.
V?
Yeah, so for y'all, do you do any implementation yourselves? You know, like you get data of like hospitals to see how they're doing, and then are you the ones reaching out? What I'm trying to say is like, are you the ones that are able to implement and hold people accountable, like these hospitals or the providers within them when they're not following protocol?
I can speak for what we are doing. You know, because we are not, we see the clinical that comes through. Sometimes that raises concern. We are talking to the individual that will bring up concerns as well. What we do is we'll do quality audits for the provider, provide education, and then also, you and everybody else has the opportunity to file complaints with the Department of Health. And that is something that our community has open to them, and we have done.
Okay, I'm asking, well, for a lot of reasons, but one, to cover to add on to what MJ said. I had a horrible experience with medication that was prescribed to me before they even made an accurate diagnose. It's really premature all the time, and talking with other young people and having the experience myself, oftentimes we suppress our symptoms to not be deemed as crazy and having to have a longer sentence, I would say, honestly. And yeah, because of that misdiagnosis, you're prescribed medication that's just not for you, not for your chemistry, and it actually makes your symptoms worse. So yeah, when I was there were only nurse practitioners that rarely interacted with me, and somehow I received a diagnosis that just didn't make sense to me. So I just like within the facility, are they allowed to make these premature diagnoses and to give you medication? Oh, go ahead.
I was just going to say, unfortunately, you're illustrating a problem that does occur, which is they typically do make diagnoses pretty quickly when somebody's inpatient, especially on an ITA. One helpful bit of information: in Washington State, you always have a 72-hour no. So for the first 72 hours you're detained, you can decline any medication. If they try to tell you otherwise, they are breaking the law.
Really?
So yes, you can decline any. However, after 72 hours, sorry, I don't have better language, you're kind of screwed. If you're involuntarily detained after 72 hours, they could prescribe anything that they think might work, and you don't really have the ability to decline that medication, which I know sounds terrifying and is awful. So
And use force. I imagine they stand there and watch you when you take the medication.
they watch
And I'm
you,
always
make sure that you're
curious.
not cheeking it. We check in your mouth. We make sure you're not slipping it in a sleeve or a sock. Yeah, we do. That's kind of how we, the sanitized words, ensure compliance. However, yes, I've seen folks use physical force we can compel medication in Washington State after 72 hours if somebody's been detained. And that's kind of the holds that we have, just like you alluded to that 14-day. Folks are initially held on a 72-hour ITA, and then that's why you do court. They establish if you're either released to community or held for 14 more days. Then they evaluate, and then they look to see if you're either detained for a 90-day ITA or a 180-day ITA. Sometimes folks are released on what we call an ITA. Also, sorry, I keep saying it stands for Involuntary Treatment Act. It just means any involuntary treatment. And then we see if you're released on a least restrictive order, and that would be where we say, hey, you're going to be released, but only, it's like, hey, you have to do these types of services. Usually it's outpatient. And following up.
And just to a little bit more information, the initial ITA 72 hours has been extended now to 120 hours.
Oh, thank you.
Yeah. And I think that has to do a lot with assessing for does this person need to be held any longer, and with the hopes of, if medication is part of the plan, that is something that is that the individual is engaged in. And the work that I've always done is I want someone to try to be as voluntary as possible, because these are your rights. And so whenever I've had to meet with somebody and say, hey, I have to call a DCR, I always, if I can, if the person's can understand me, I let them know this is your right, and once you go under a detainment, you lose rights. But it's of course, it's up to the individuals who's doing that assessment.
Thank you, CJ, for that.
No problem.
It's been about 10 years since I worked inpatient, so I need to brush up clearly.
Yeah, no, thank you very, very much. I just want to say, one, if you have thoughts, or if somebody's already working on improvements to 1860, we'd be interested in talking. And if no one is, but you have ideas, we'd be interested in talking as North Star, maybe carrying something forward. The other is, I don't know. I mean, I know you all are limited. You're not in the hospital per se, so you don't know what's actually happening. But if you're at all interested we're building an advisory board of young people with lived experience, to the degree you want to have contact with them and conversations around how to increase quality of care by maybe increasing some feedback loops / accountability. I think people would be really interested in that. So we're going to close, but MJ, do you have one last comment that you're burning to make?
Well, I can write a follow-up email. It's just some stuff about community reintegration, and I was like, well, maybe there could be a seminar that can be done prior to youth and young adults being released that can have different facets underneath it. So it would be teach on social groups and healthy family relationships and stuff like that. But I could write an email delineating.
Well, yeah, and I would also encourage you to bring it up at the next steering committee meeting with V and Rosemary and other young people, because that's exactly the kind of thing they're working on.
Okay, sounds good.
Great. Well, any closing comments from the presenters? And I guess if you hang around Jimmy T long enough, you know what I'm going to say in advance, which is thank you for being here. And it's not the last time we want to have the benefit of you. We talked about a 3-part training. So I really hope that you'll continue to come back and be a partner with us as we try and put this together.
I just want to say one thing. Having that lived experience, as difficult as it is for anybody who has gone through a moment of struggle with mental health, where you're at now in your voice and your ideas and sharing your experience is so powerful to help with the movement of improving our healthcare system. So I just want to thank you for everybody and what your goals, and it's really good to see the passion.
Yeah, I would just second what CJ said. So thank you so much. And yeah, please never be quiet. Always keep trying to help address systems. They're going to take a lot of loud squeaky wheels to see change happen.
Yeah.
So we're glad you're a part of it. And thank you so much for having us, Jim.
Thank you.
If you have any follow-up questions, I think I'll put our emails into the slide deck too, so that folks can see that, and then I'll get that over to Jim. So yeah.
Great. James, did you want to say anything?
Yeah, I'd just like to echo both what Scott and CJ said, and I'll probably speak for the both of them by saying that the people who work at the MCOs really are passionate about helping people. So if you ever need anything, please reach out to them. They will do their best to assist you. And it's been a pleasure being here, and I look forward to working with everyone ongoing.
Great. So you're the one that got closest. Does that mean yes, you're coming back?
Yep, I'll be back.
Great. Thank you all very, very much. You're welcome to stay for the next part of the conversation or exit, whatever you prefer. So, and I have to say, I was a little worried that, is this conversation going to be too dry? But I think it's so relevant to what we're all dealing with. It was good to go a little overtime because it is important. And as I say, it's an area that I learn more about every time I have the conversation. So what I want to do now, and we're only going to have a little bit of time to tee it up. Maybe the next meeting, we're going to really go in depth. And this is me educating, not lobbying or advocating. But as you know, one of the pieces of our contract with Healthcare Authority is to identify gaps in the system. And one of them clearly is how we started off at the beginning, which is coalition is great, but it's not an actual bed for a young person to be in to avoid being exited into homelessness. So I just want to update you that we do have a legislator, and we expect to have a bill soon that will identify 2 sites, 6 to 10 bed house on the west side and the east side. It's going to be named the Bridge Residential, and it really is that soft landing for someone who either has a bed available in 1 day or 30 days or has no bed at all. Because we did find that some of the decision to discharge was so hard and fast that some young people reported, I did have a place to live, but it wasn't ready for a period of time, or there was a condition of I needed to be clean and sober or on my meds before I could move back to a relative or friend. And they lost that opportunity because they were discharged again to a drop-in center or a shelter. So we do believe we're going to get a bill dropped soon. We're meeting with the legislator to review the draft. We have somewhat of a chance of being in the governor's budget. Which will then, the benefit of that is not only do you get an early start, but then the state employees like Healthcare Authority folks, Office of Homeless Youth folks, other state employees can also advocate for this need if it's in the governor's budget. There's a couple questions, and I don't know that we'll have time, but I'd like to, a couple questions that we're trying to figure out is, I think these programs need to have capacity for both mental health and substance use disorder, because I think they're both sort of relevant. One might be more primary, but as opposed to this is only SUD and the Bridge Residential is only for, this is only for those who have a psychiatric or a diagnosis out of the DSM-4, as opposed to having this capacity for both. Any thoughts or comments off the top about, there's other questions, but for today, I'm going to just make sure I don't list 3 or 4 questions and we get to none of them. This is one I'd like to see if there's any immediate feedback on the capacity of the Bridge Residential staff to have both SUD, meaning Suboxone, fentanyl expertise, but also anxiety, depression, PTSD, schizophrenia. Thoughts, comments, especially from our provider friends?
I don't know if I'm the only provider on here or not.
I think Dustin is.
Oh, okay. I don't have an issue with it at all as far as whether it's behavioral health is behavioral health, and it's usually a very inclusive term and not an exclusive term. And I look at it as behavioral health is either or, and behavioral health could also include physical health. So I'm there for, I think it's hard to separate out, oh no, this one's needs this housing more so than somebody coming out of this treatment facility. That's just, that gets awfully muckety in my mind.
Yeah. Justin, can you speak to this? And I just want to be clear that 30-day be clean. Some programs have it, but some families have it as well. And we
Right, and for
Go ahead,
sure.
please.
I
From Cuckoo Hunters and Everin, I need to add, yeah?
yes,
Yeah.
little bit on the spot here. Let me can you just recap your question real quick so I can?
Yeah, of course. And I don't want to put you on the spot, and this isn't the
No
last
worries,
time we'll talk about it, but it's really about if we had the bridge residential, which was for 1 to 90 days, kind of a
Okay.
soft landing, but to focus to where's the next best long-term place for this young person, driven by the young person, not decided by staff, but young person, this is where I can go. But there's some providers have said, well, we're really good at mental health, but I don't know if we know much about fentanyl. And other SUD providers have said, this is our sweet spot. And yeah, we deal with PTSD, but I don't know about schizophrenia. So do we accept that it's probably one or the other? Do we provide training? The need seems to be for both, but I'd love to hear your thoughts.
As somebody, okay, so as having been housing staff and working with an agency that focuses on homeless youth, you're going to get all kinds, and just training as best you can on all of these topics. Especially coming in, you're not going to know a lot, but I think we have in our housing programs, we mandate 24 training hours a year. Like, we need to keep up on changing topics. The new editions of the DSM are like, my on-team therapist is constantly reviewing, and also like not just mental health and behavior issue or instances like narcotic use or alcohol abuse. We also have like major CSEC concerns come up all the time with trafficking, and like you need trainings on those as well. It's a lot, and building a residential program from the ground is gonna be a big ordeal, but it's super important and it would be amazing. I hope I answered your question.
Yeah, you did. No, it's a conversation. It's not a test. Like I say, as a student, I don't want any tests. Anybody else? I'm going to come to you, MJ, but I don't know. We've got some other expertise. Anybody else want us? And I know we're losing folks. It's coming to that witching hour, but anyone else want to say anything about this question? Dual diagnosis, co-occurring disorders versus get good at this. MJ.
All right, so some of the stuff that comes to my mind is it going to be like a cohesive unit? Like when you have people that are going through withdrawals, it's a little bit different than people that are going through like, mental health disorders. But at the same time, like what Dustin had said about proper training and making sure that like they're pretty well-rounded as a provider to be able to handle these types of situations as they arise is pretty ideal. I know like I wouldn't want to limit services to someone if they weren't sober, but they still want help. So I know that like I was doing some notes earlier, and I know a lot of these places, like with cost considerations, it's like $300 to $450 a month to share a room with someone else. And those would be sober living environments, but they would also be in a rigid, like, you have to be inside by a certain time, you have to abide by certain rules and stuff. So just to take that into consideration, and in addition to like what kind of service would we provide? Would it be more comprehensive? Would it be more specific? And what are the advantages and disadvantages of both sides? And I think that's kind of where we're at currently. I recall Justin was saying something about like trafficking and stuff like that, and how that can cause more issues. So how to mitigate those circumstances and to really build a cohesive unit.
Yeah, well, to that point, in fact, these will be people who are coming out of inpatient. So hopefully they've had some period of time to go through the detox process, and now they're trying to protect that. Quite frankly, it probably will be that you're required to be in some kind of healing, recovery, whatever the word is. Now, someone might be in there for a week and relapse, so then the staff will have to decide, what do we do with that? But I think what we're thinking now is these are people who have gone through mental health and or SUD treatment and coming out trying to preserve the benefit of that, but also more importantly, identify a long-term housing. So, all right. Any closing comments before we, yeah, I'm happy to keep talking, but I also, Aaron, did you want to put your thing up there for those with lived experience to get their
Yep.
payment?
Yep, happy to. Let me launch that poll. We'll leave it on the screen for just a few minutes. If you think you may be available or eligible to receive a stipend for your time, please take a moment to respond. And our eligibility criteria are, sorry, let me launch the, there we go. Are you able to see that on the screen?
Not yet.
Not
We
yet.
can hear you
Okay.
stressing about it
Launch.
though.
Yeah, good, great. Okay, now it should be going.
There we go.
I was
Thank
gonna
you.
say, our criteria are if you have lived experience of inpatient behavioral health programs and your time is not being compensated by another source. So thanks for bearing with me while I got that on the screen and I see people responding. Appreciate it.
Great. Those of you who are providers who have young people, please know we're trying to build up the advisory council for the bridge. We pay a stipend of $75 an hour. As you heard with the MCOs, we're looking for ways for these young people to also advise other entities in the system. And there's some talk of having a day long or a half day convening of young people talking about the behavioral health system. Thank you very much, Aaron. Yeah, and again, any feedback, you'll get a survey. I know the group is small now, but please complete the survey, or if you want to just send an email. We are trying to strengthen the value of the coalition and keep you so it's worth your time to come. And we'll be contracting with Sarah Spire, who you may know from Spokane, who's got some great expertise in the behavioral health world, and she openly speaks about her own lived experience to help with trainings and identify trainings and that sort of thing. So we want the feedback. We know coalitions are limited, but we do think the coalition plus the Bridge Residential and a youth and young adult advisory council surrounding that could really be a powerful vehicle. So any closing comments? All right. Thank you again, Scott, and those of you who came. Thank you for speaking up, Bridget.
Thank you.
Thanks so much.